Hello, anesthesists. Today we're going to review the 2024 AHA/ACC Guideline on Perioperative Cardiovascular Management for non-cardiac surgery. Now, as this guideline is pretty extensive and, let's be honest, can feel a bit overwhelming to get through, we're going to break it down into 3 manageable sessions and really focus on the key points. So today is our first session.
Right. So in this session, we're going to build a really strong foundation for understanding how these new guidelines are likely to shape our day-to-day practice. We'll kick things off with the key changes. What's new in 2024? Then we'll get into the absolute core of our job, risk assessment, looking at both the surgery itself and, of course, the patient. After that, we'll explore the roles of functional capacity and frailty, 2 areas that are getting a lot more well-deserved attention. Then we'll dive into the updated strategy for preoperative cardiac testing, which is much more selective now. And finally, we'll have a quick look at what's coming up in the next sessions.
Okay, let's get stuck in. It has been a full decade since the last major update back in 2014, and in that time there has been a huge amount of new evidence published. So this 2024 guideline is really a massive effort to pull all of that new data together. The whole point is to move us towards a more patient-centered, team-based, and evidence-driven approach to perioperative care. The goal here is simple: improve patient outcomes by making smarter, more selective decisions about who we test and when we intervene.
Now, this slide is basically the executive summary of the whole document, so let's take a minute to look at the bits that will really impact our practice. Point 1. This stepwise, team-based approach, well, that's the central philosophy. It's all about getting away from that old model of just getting cardiology clearance and moving towards a collaborative discussion, surgeon, anesthetist, physician, all talking together. Point 3 is a huge theme throughout: the judicious use of stress testing. We're getting away from just testing everyone and really focusing only on those patients where the result is actually going to change what we do. Point 5 is a crucial, very specific one for us to flag preoperatively: stopping SGLT2 inhibitors because of that risk of aglycemic DKA. And of course, point 6, the formal recognition of MINS, myocardial injury after non-cardiac surgery. This isn't just a troponin leak anymore. It's now identified as a distinct prognostic entity we have to be on the lookout for postoperatively. And as we'll see, our preoperative assessment is key to establishing a baseline for that.
Before we really start dissecting the specific recommendations, it's absolutely vital that we're all speaking the same language. The class of recommendation, or COR, tells us how strong the recommendation is. Class 1 is a firm "you should do this" because the benefit is clear. Class 2A, which uses the phrase "is reasonable," suggests the benefit probably outweighs the risk. Class 2B, may be considered, means we're less certain about that benefit-to-risk ratio. And then you have Class 3, which is either no benefit or harm, and that tells us in no uncertain terms what not to do. The level of evidence, or LOE, is all about the quality of the data behind it. Understanding this grid is really the key to interpreting the entire guideline properly.
Right. Let's build the foundation of our assessment. Everything we do flows from first understanding the risk from the surgery itself and the baseline risk our patient is bringing with them. And this is where the 2024 guidelines introduce a really significant and I think very welcome simplification.
So gone is the old 3-tiered system of low, intermediate, and high-risk procedures. It's been streamlined into a much more functional 2-tiered system: low risk versus elevated risk. The threshold is a predicted 1% risk of a major adverse cardiovascular event, or MACE, within 30 days. And this brilliantly shows the key concept. Risk isn't just about the procedure anymore. It's about the combination of the procedure and the patient's own health. So you could have a typically low-risk surgery, but in a very frail comorbid patient, that combined risk could easily push them over that 1% threshold, classifying them as elevated risk and triggering a much more detailed evaluation.
Alongside the risk level, the urgency of the surgery is the other critical factor that dictates how we proceed. For an emergency case, our ability to do a big workup is obviously limited. The priority is saving life or limb, and the conversation shifts to how we're going to manage things intraoperatively and postoperatively. For elective cases, we have the luxury of time to fully investigate and optimize the patient. But it's this time-sensitive category, and this includes many cancer operations, where our clinical judgment is absolutely key. We have to carefully weigh the potential benefit of doing more cardiac tests against the very real harm of delaying a necessary operation.
So how do we actually put a number on that patient-specific risk? Well, we have several validated tools. The Revised Cardiac Risk Index, or RCRI, is the classic one we all learned. It's simple, 6 predictors, easy to remember. But its main limitation is its age. The data is from the 1990s. The NSQIP calculators, that's the National Surgical Quality Improvement Program, are more modern and robust.
What's really interesting here is the evolution you can see on the slide. The NSQIP calculators bring in two absolutely critical things that the RCRI doesn't have: the ASA class and, most importantly, preoperative functional status. This shift acknowledges that how a patient actually functions in their daily life is an incredibly powerful predictor of how they'll handle the stress of surgery and anesthesia.
And that brings us perfectly to our next section. We're going to look at two concepts that have been given much more importance in these new guidelines: functional capacity and frailty. This is all about moving beyond a simple list of diagnoses and really trying to get a feel for the patient's true physiological reserve.
Functional capacity, which we measure in metabolic equivalence, or METs, is a cornerstone of the entire assessment algorithm. It's essentially a proxy for a patient's cardiorespiratory fitness. The critical number you need to burn into your memory is 4 METs. A patient who cannot achieve 4 METs of activity without getting significant symptoms is considered to have poor functional capacity, and that is a major red flag. It is a powerful, independent predictor of perioperative complications, including MACE.
So how do we estimate METs in a busy preoperative clinic? I mean, we don't need to put every patient on a treadmill. The Duke Activity Status Index, or DASI, is a fantastic, validated questionnaire that links everyday activities to MET levels. This slide shows it brilliantly. You can simply ask the patient, can you climb a flight of stairs or walk up a steep hill without having to stop? If they say yes, they've just shown you they have a functional capacity of about 5.5 METs, which clears that crucial 4 MET threshold. It's a quick, easy, yet remarkably powerful assessment tool.
The guidelines also place a new and really important emphasis on assessing frailty. Now, frailty is different from just age or having comorbidities. It's a state of increased vulnerability to stressors because of a decline in physiological reserve across multiple body systems. It is a massive independent predictor of postoperative problems, morbidity, mortality, and failure to get back to living independently. The guidelines don't mandate one specific tool, but they do give a Class 2A recommendation for using a validated tool in older adults. Even simple things like the clinical frailty scale can give us huge amounts of prognostic information and really help guide those crucial shared decision-making conversations about whether surgery is the right choice.
Another major change is the formal recommendation to use preoperative biomarkers. This is a big step forward. A preoperative B-type natriuretic peptide, so either a BNP or an NT-proBNP, now has a Class 2A recommendation for risk stratification in older patients or those with known cardiovascular disease who are having elevated risk surgery. An elevated level can actually reclassify a patient into a higher risk category and might make you think about more intensive perioperative monitoring. And what's more, getting a baseline high-sensitivity troponin gets a Class 2B recommendation. Now, this isn't to diagnose an acute MI before surgery, but it's all about establishing a baseline. This is absolutely crucial for being able to accurately interpret postoperative troponin rises and to diagnose MINS.
Right, let's move on and see how all this information, the surgical risk, the patient risk, functional capacity, biomarkers, all comes together to guide our strategy for any further cardiac testing. The key principle here is selectivity. We're really moving away from the old approach of test everyone.
So the first test we always think of, the 12-lead ECG. The recommendations are actually quite nuanced. For patients with known cardiac disease, a preoperative ECG is reasonable to act as a baseline and to check for any changes. Interestingly, it also gets a 2A recommendation for asymptomatic patients without known disease, but for the specific purpose of refining the clinical risk assessment. The crucial takeaway here, though, is the strong Class 3 no-benefit recommendation against routine ECGs for asymptomatic patients who are having low-risk procedures. This is a really key area where we can cut back on low-value care.
Next, what about assessing left ventricular function, usually with an echocardiogram? Well, the recommendations here are very clear and, I think, wonderfully symptom-driven. There is a Class 1, a strong recommendation for assessing LV function in patients with unexplained breathlessness or in those with known heart failure who have worsening symptoms. It's all about investigating a clinical change. And on the flip side, there's a strong Class 3 no-benefit recommendation against routine repeat evaluation of LV function in patients who are asymptomatic and clinically stable, even if they have known heart failure. If nothing has changed clinically, repeating the echo is very unlikely to change your management.
And now we get to one of the most common questions in perioperative medicine. Who actually needs a stress test? The new guidelines give a much clearer, and I think you'll find a much more restrictive answer than we had before.
So, the crucial point is this: stress testing gets a Class 2B recommendation, which means it may be considered, but only in a very specific group of patients. First, the patient must be scheduled for elevated risk surgery. Second, they must have poor or unknown functional capacity. But there's a third, vital qualifier: The results of the test must have the potential to actually change management. If the patient and the team are going ahead with the surgery regardless of the result, then the test provides no benefit and just adds cost and delay. And notice that strong Class 3 recommendation against routine testing in patients with good functional capacity. Their ability to do their daily activities is, in itself, a sufficient stress test.
Now, if the decision is made to go ahead with testing, the choice of test matters. An exercise stress test is always preferred if the patient is able to do it properly. It gives us direct physiological information about ischemic thresholds and exercise capacity, which is powerfully prognostic. For patients who can't exercise, we turn to pharmacological testing. The choice between a dobutamine stress echo and a vasodilator nuclear scan really depends on local expertise and patient factors. And as anesthesiologists, we need to be aware of the key contraindications. For example, avoiding vasodilators in severe asthma or dobutamine in patients with a significant LV outflow tract obstruction or tachyarrhythmias.
An interesting addition to the guideline is the formal inclusion of coronary CT angiography, or CCTA. It also gets a Class 2B recommendation as a potential alternative to a functional stress test in that same select patient population, elevated surgical risk with poor functional capacity. The main strength of CCTA is its very high negative predictive value. A normal CCTA essentially rules out significant obstructive coronary artery disease, which is very reassuring. It gives us anatomical information rather than physiological, which can be useful, but it is certainly not meant to be a routine screening tool.
And finally, we come to invasive coronary angiography. The guideline is emphatic on this point, issuing a Class 3 harm recommendation. Let me just say that again, harm. Routine preoperative angiography, simply to look for coronary disease, is not recommended. Major trials have shown us that prophylactic revascularization before non-cardiac surgery in patients with stable coronary artery disease does not improve outcomes. In fact, it might actually cause harm from procedural complications and by delaying the necessary surgery. Angiography is reserved for patients who have an indication for it anyway, independent of their upcoming operation, like an acute coronary syndrome or very high-risk features on their non-invasive tests.
So to quickly recap this first foundational session, we've seen a paradigm shift towards a simplified, much more practical risk framework, low versus elevated risk based on that 1% MACE threshold. We've highlighted the critical, elevated importance of assessing a patient's real-world functional capacity and their frailty, moving beyond just a list of diagnoses. And we've walked through a highly selective, stepwise approach to diagnostic testing, always coming back to that most important question: will this test actually change how I manage this patient?
This detailed preoperative assessment we've talked about today really does create the foundation for everything that follows. In our next sessions, we'll build directly on this. We'll dive deep into specific management strategies for common comorbidities, like coronary artery disease, heart failure, and valvular disease. We'll also get into the complexities of perioperative medication management, a critical area for us, before moving on to anesthetic considerations and postoperative care.
So, I'll leave you with a final thought to take back to your own clinical environments. Reflect on this first part of the guideline. Is it the new two-tiered risk system, the formal emphasis on frailty, or perhaps the more restrictive approach to stress testing? Consider which of these updated recommendations you think will have the most significant impact on your daily preoperative workflow and your conversations with your surgical and medical colleagues. Thank you for joining me for this first part of our deep dive. I look forward to seeing you for part 2.